Well, good afternoon. We'll go ahead and get started. My name is Jeff Skillen. I'm the Chief Growth Officer with Evolve Adolescent Behavioral Health. It's a real pleasure for us to be able to put on relevant topics for continuing education. And this afternoon, we're very pleased to co-host this event with our friends at Sunrise Residential Treatment Center. For the next 90 minutes, the topic will be understanding trends and preventative factors in teen suicidality. And we're honored to have Allison Orsina, the Chief Clinical Officer at Evolve Adolescent Behavioral Health, and then Brad Simpson, who's the Research and Development Director with Sunrise Residential Treatment Center. A couple of housekeeping things. So I know many of you have attended a number of these webinars. Please locate the Q&A box so that as the presentation moves forward, you can go ahead and send those over, and then our moderator will handle those. Also, the chat can be used if you want to offer any comments or concerns. But if you want to make sure that our presenters address something specific in terms of their material, please use the Q&A. So chat should be used primarily if you're having technical difficulties or things like that. A reminder that this is being recorded and the slides will be available via PDF online. So you'll have those materials as soon as the event concludes. You also received an email indicating the information regarding redeeming your continuing education credits. I won't go over this slide, but this slide basically points you to the attendee dashboard, and we're prepared to answer any questions that you may have so that you can redeem your CEs. And here's a listing of the licensures that are applicable for today's content. Okay, and with that, our presenters are going to introduce themselves. So I'm going to step off the side of the stage, and I'm going to hand it over to Brad. So Brad, take it away.
Yeah, thanks for everybody joining us. We're happy to have you today. Anyways, it's good to be with you as we kind of go through. I'll inform you kind of the objectives that we're going to hit and go through that way. But maybe I'll have Allison introduce herself first, and then I'll introduce myself. Then we'll jump in with you. So.
Sounds good. Thanks, Brad. My name is Allison Orsina. I'm a licensed marriage and family therapist in California and have worked with Evolve since 2016. I'm intensively trained DBT therapist and helped launch our first DBT program for teens in residential at Evolve. And in my role now as Chief Clinical Officer, I oversee clinical for all of Evolve and drive clinical procedure, strategy, development, and training. I have a lot of experience over all these years and beyond working with suicidal individuals. And that's a particular passion of mine, is working with teens in crisis. So I'm happy to share some of the DBT approaches today of managing those situations.
Yeah, thanks, Allison. It's good to be with you too. I'll just introduce myself real quick. My name's Brad Simpson, as you heard. I've been at Sunrise Residential Treatment Center for about 20 years now, and served in a lot of capacities. Anyways, appreciate the work I'm able to do and the work we do with adolescents. I also work at Southern Utah University and am the director of the Bachelor of Social Work program there. And really between those roles and teaching and training and consulting, I also have a consulting company. We do consulting around the country, also do trainings around the country in DBT. So all of my degrees, I have a bachelor's, a master's, and a doctorate in social work. And I always tell people I have all 3 degrees in social work because I couldn't get any other degree. That was just what they gave me. So anyways, that's where my passion is in social work and the work we do that way. But I think because of all of that and working with adolescents and working in every level of care, from outpatient to intensive outpatient to residential to inpatient, has really given me a nice view of different modalities, different interventions that we use. But the reality is And we know this, that the suicide crisis that we're dealing with in America is only growing. And with Allison, it was nice to be able to join with Allison and her passion and work she does with adolescents around suicide specifically. And so those are kind of the objectives we want to hit is one, understand and identify what the prevalence of suicidality is among adolescents in the United States. Understanding the developmental causes associated with suicidality. It's interesting. Sometimes I think we believe we know more about suicidality than we actually do. There's just so much that still needs to be researched and understood, and we'll hope to highlight some of what we do know, but also what we don't know, I think is just as important to understand what research do we have and what research don't we have and where are the gaps, I think is also really important and critical to talk about. And then we'll really hit and identify what are 3 interventions to help reduce vulnerability to suicidality in adolescents. And then 3 essential components in suicide intervention, prevention, and coaching. And so obviously with Allison and I both being DBT oriented and intensively trained in DBT, we do tend to look through that lens and approach it through that lens. And so just know that that's part of what you'll be getting today is not only the research and those pieces, but what are some specific interventions in that regard. So um, I'm just going to show you the numbers. When we look at prevalence in I mean, this is kind of a global picture of mental health crisis nationally. This is from a representative sample of high school students, and you can see that the number of students in 2021 that this sample comes from. This is from the CDC and the work that they do. And this is given again to high school adolescents. So you can look as you look at it, those that experience persistent feelings of sadness or hopelessness, and you can see the trend, right, as it moves up from 2011 to 2021. Now remember, we know COVID was starting to occur just after, so we don't see the data as we're hitting just after COVID, which we know from early research and early things happening that that's continuing to trend up as well. But anyways, that's high. This is 42 represents 42%. So of the 17,232 adolescents in high school, there's 42% said they experienced persistent feelings of sadness or hopelessness. And so the indicator, you can see red, green, or yellow is an indicator that that's trending up versus down. Those that experience poor mental health, that was one that was added, a question that was added in 2021. So we'll see that in the next years. It's done every 2 years, as you can see this sample. And so we'll see in the next 2 years what that looks like. As we look at seriously considering attempting suicide, right, we see that trending up as well at 22%. Those that actually made a suicide plan, and I'm sharing this kind of detail because we're going to get that detailed through this. So if you'll notice and remember these numbers, these will help you with the next things we talk about. But those that made a suicide plan, right, in 2021, we had 18%. Those that attempted suicide, we've seen that grow as well. We're at 10% that actually had at least one attempt, is what we're looking at. And then those that were injured in a suicide attempt that had to be treated by a doctor or nurse, that was 3%. And so that one I thought that was interesting. I don't know that that's comforting in any way that stayed about the same, because the reality is, as we know, that boys are using more lethal means for suicide and having less attempts, where girls have more attempts with less lethal means that may not have needed to have intervention. So I think that's something to just kind of look at and be aware of as we look at the numbers and the mental health crisis across the board. So as we kind of look at the next piece, that this is important. We don't talk a lot about suicidal, self-injurious thoughts and behaviors. We're not going to talk a lot about that, but it's still important to have some context as we're talking about suicide and what we do know. When we think about the emergence of suicidal or self-injurious thoughts and behaviors, um, part of that is what we call non-suicidal self-injury. And so we don't spend a lot of time talking about non-suicidal self-injury, but it's important for you to have some context for it, so that as we get into what we know and what we don't know in the research, it will make more sense. But incidents of suicidal or self-injurious thoughts and behaviors we know are rapidly increasing among adolescents and young adults. And really what we're seeing is that typically they're starting around the age of 12. So when you kind of look at this developmental idea, what do we know starts to happen around 10, 11, 12? And that's really developmentally, right? When we know that puberty is starting to occur, those changes are happening. And that's also about the time we're starting to see this rapid increase that's occurring there. So among adolescents from both inpatient and outpatient samples, the first onset, this is important to note, the first onset of suicidal ideation was reported to begin 4 to 6 months before the first engagement of non-suicidal self-injury. So when you think timeline, we'll kind of start to talk about that. But the first onset of suicidal ideation, remember, was 4 to 6 months before the first engagement of non-suicidal self-injury. So what we would naturally start to think is maybe it happens on a continuum, right? Where you have this idea of you have the first thought of suicide ideation happening, or that first onset, which then progresses and leads to non-suicidal self-injury, which then you'd think, okay, maybe on the continuum that then leads to planning of suicide, and then that leads to attempts of suicide and maybe a successful attempt. So you can see that naturally, I think most of us in the field tend to believe this is a continuum. And I'm about to share that may or may not be the case. So the first onset of non-suicidal, let me just go back if I can. This one more thing to be aware. The first onset of non-suicidal self-injury preceded suicide planning by 3 to 6 months. So think about this. And then a suicide attempt by 1 to 2 years. So we can't say it's linear, because on the one hand, you have this first onset of suicide ideation was reported to begin 4 to 6 months before engagement of non-suicidal self-injury. Then you also had the first onset of non-suicide self-injury preceded planning by 3 to 6 months. So if you kind of think timeline, right, 4 to 6 months, you have first onset of suicidal ideation. 4 to 6 months, you have the first engagement of non-suicidal self-injury. 3 to 6 months, you then have your suicide planning occurring, right? And plans actually start to get made. And then 1 to 2 years, suicide attempts. So what we're actually seeing is that non-suicidal self-injury and suicide ideation may emerge around the same time, or somewhat before non-suicidal self-injury. So that's kind of what the latest research is showing us. So,
and I think that really tracks with what we see on the ground at Evolve too, in terms of many clients using NSSI as a means of suicide prevention. So if they want to avoid suicide attempt, they might cut instead, for example.
yeah, great point. So this is also, as we look at the emergence, most youth transition from suicide ideation to suicide planning or attempting within the first year after the onset of their first suicidal thought. So basically, they have the thought of suicide, and then within the first year after the onset of the first thought, most youth transition to planning or thinking of a plan of what they want to do. 63% of adolescents transition from suicide ideation to suicide planning in 1 year. 86% of adolescents transition from suicide ideation to suicide attempt within 1 year. And then 88% of adolescents transition from suicide planning to suicide attempt within 1 year. So I think it's interesting to look at, and And I think when we're doing safety assessment or risk assessment, hopefully knowing this information gives you some idea. And you could ask such as, when was the first time you ever thought of hurting yourself, right? We know that now the clock's ticking and we know what the research is showing. Same thing with, when's the first time you had a plan to hurt yourself, right? And if we understand that, we also know the clock's ticking and there's pretty high likelihood in that first year there will be an attempt. So those I think are important indicators as we look at not only this idea of how do we start to prevent suicide, but what can we do in that process. So
Oh, clarification from the Q&A
yeah.
box needed around when we say suicidal ideation, are we referring to thoughts of suicide in absence of clear planning?
Yeah, great question. So yeah, it is in absence of clear planning. So that's why you'll hear, just as we're talking about, you may have the first thought of the idea that I could hurt myself or kill myself. Then what we start to see is that 3 to 6 months after, I then move to a plan or having clear planning occurring. So great question.
And are these trends representative of kids who are not in treatment?
Yeah, so this again is from those that are inpatient and outpatient as well. So we're seeing that across the board. Yep. Good question. Um, so here's what we don't know, and here's what the gaps in the research are. And I think this is important to note because sometimes we assume we might know more than we do. So some of the evidence suggests that an understanding of the concept of death, when we think developmentally, really begins to form around age 5. Um, I think back, I think a lot of even my first memories are from age 5. I don't know that I remember a whole lot before that. Maybe that's true for you. Um, in, in fact, I was talking to my little boy that's 5, and we'll just be sitting sometimes at the counter, and he'll just start telling me something that's happened like a week or two ago. And it's stuff I would never hear otherwise. And so you wonder, right? How do we really gather that data or understand what's going on developmentally at that age? What's the impact of the experiences we're having? But a lot of those early memories really start to occur at age 5. So it makes sense. Maybe your first concept of death starts to form around that time. And then the transition from early to middle childhood really is what we're highlighting or starting to see as maybe another vulnerable period for the emergence of suicide, self-injurious thoughts and behaviors. So when I say self-injurious thoughts and behaviors, what gets lumped in that category is non-suicidal self-injury as well as suicidal thoughts, right? Both would tie into that category in the research and in the literature. So few studies really exist focusing on child samples with youth between 9 and 12. And you can understand why there's probably barriers to that and getting data at those ages. There are a lot of barriers to being able to get that. And then obviously even fewer in the 3 to 8 age range in terms of how do we really collect data and get good sample sizes in that process. So but we just don't know. So it's interesting when you think developmentally, we're seeing is actually puberty onset is happening earlier and earlier, especially with our younger girls. Some of that's occurring. So you can see how important that 9 to 12 is. The research is showing us 12 is probably that first onset. It could be earlier. We just don't have a lot of data to confirm that or not confirm that in the process. And so I think that's important to know. And then, of course, gaps remain regarding when or how self-injurious thoughts and behaviors first emerge and then progress really from early childhood to adolescence across the board. So a couple other just research gap. There's still little known on the risk of self-injurious thoughts and behaviors from first emergence to suicide behavior, as well as the risk factors that predict those. There's a lot of questions that need to be researched, including understanding the risk of self-injurious thoughts and behaviors from first emergence to suicidal behavior. And I'll show you kind of what we're talking about there. And then also this idea of what predicts and influences the transition between ideation and actual behavior. we have some ideas and we have some protective factors we're aware of, which we'll start to talk about that and break that down more. But there's still a lot we don't know about that true influence and emergence. And then how do interactions among multiple risk factors predict the emergence and the course of self-injurious thoughts and behaviors from childhood and into adulthood? So those are the other pieces that we don't know a lot about. This is actually from Sheila Crowell. If you're familiar with her, she's at the University of Oregon. She used to be at the University of Utah. If you look her up at the University of Utah, she has done a lot of work in regards to research, and I'll share some of her research with you. But you can pull up her profile and look up all the research articles she's done. But she's really been one of the first to really start to look at this in a suicidality through a developmental model and understanding what that looks like. And so that's kind of what I'm going to share a little bit of some of her research with you. But essentially, this graph isn't easy to see for probably many of you. But I hope to give you an idea of this is just one example as we look at lifespan development and a model of emotional dysregulation. So meaning what does lead to, so when we think of, there's a lot we need to learn about this emergence from age 5, we have that first concept of death, all the way to age 12, where we really have pretty good documented ideas related to the onset of suicide. What's happening and how do we follow that emergence that's occurring? And so these are some things that we do know and some things that we hypothesize in that process that may be factors that are important. So we kind of broke it down into 3 factors, right? We're looking at of course, just age and developmentally where they're at. Then we're looking at the biological processes that we know occur and may influence one another in regards to emotional dysregulation. As we know, emotional dysregulation is what's really leading us to suicidal attempts and suicide ideation. And then we're looking at what are behavioral manifestations that we see in that process. And then what are contextual mechanisms that may contribute to the dysregulation? And so it really is kind of this lifespan developmental model of across those factors or those domains, right? So the first one, if you've heard of epigenetics, and so we know that genetically we have some genes that get turned on or not turned on based on, and some predispositions that take effect based on environmental factors that contribute to it. So epigenetics is this idea of gene environment interaction, right? And they did a lot of research. They were able to look at how many of you've seen, if I had raised the hands, I'd have you raise hands, and just think in your mind, if you've ever seen the movie Matilda. Matilda's I mean, it's awesome. They've remade it like 12 times, I think. Now just a few, but Matilda's a great example when I think about gene environment interaction. And some ideas around that and what we're learning and what we've learned. So if you remember, they actually made a new Netflix version. If you haven't seen it, it's by Ronald Dahl. And it's fantastic. So go watch it, you'll enjoy it. But Matilda, you remember, you have on the one hand, for Matilda, you have her parents, which are a really nice example of people that were very invalidating, right? And in fact, you remember Matilda sitting at the dinner, not the dinner table, actually. She wanted to sit and talk and or read, and they would sit in front of the TV and eat dinner. And then they'd turn to Matilda and be like, Matilda, reading's for dummies, right? Nobody reads. We watch TV in this family. And then dad would tell her things like, Matilda, I'm smart, you're dumb, right? And kind of go into those pieces. And then you had, on the other hand, you remember Miss Trenchpool? She was the principal, and kind of this really nice example of invalidation again, right? And you remember the little boy that eats the chocolate cake? And then he has to eat the chocolate cake in front of the whole class. So that's just great examples of invalidation. And then if you remember Miss Penny was a nice example of a teacher, right? And this teacher, she was very validating, right? Took Matilda in, cared for her. And so I'll explain why this matters to epigenetics as we think about it and understanding this concept. But if you think about it, they did actually some research. If you've heard of the ACEs, the Adverse Childhood Experiences survey, it's one of the longest running studies they've done to look at the impact of adverse childhood experiences, and how it predicts or impacts us later in life, right? And so what they found was people that had a uh, is it Miss Honey? It's Miss Honey, not Miss Penny. Miss Honey in their lives. Allison, you're gonna have to correct me. The people that have found a Miss Honey in their lives, like a teacher, somebody who was validating, present with them, and it didn't have to be a lot high frequency. It was just somebody that was there that had kind of this unconditional positive regard and validation as part of them, actually helped those in childhood later into adult life absorb a lot of these toxic and adverse childhood experiences they had, and helped reduce uh, risk factors that they maybe had met because of those experiences they'd gone through. So I think it gives a good idea of interesting that we talk about epigenetics. If I may have alcoholism in my family, but if I never drink alcohol, that gene never gets turned on, right? So I may be prone to alcoholism, but if I never drink, that never gets turned on. We see the same thing happening emotionally too, whether it's for depression, it could be other factors, and with trauma and adverse childhood experiences. So it's always nice to share the other side to say, hey, those who have gone through adverse childhood experiences, if they did have somebody like that, maybe those genes don't get turned on later in life for them as well, because that was a protective factor. And I know we'll go more into that. But again, it's that gene environment interaction. So we have some that were predetermined due to early temperament, right, as another factor. Maybe you had difficulty soothing. You can see that. Negative parenting behaviors, that would be invalidation, right, or invalidating environment. I'm smart, you're dumb. Her parents were a really nice example of that, which then can lead to this idea of tantrums or aggressive behavior problems, right? Because if people won't take me seriously early on, then all behavior is functional, right? So then to get my needs met, I increase the extremity of my behavior, which then hopefully gets me taken seriously and my needs met. That's really the function that we're working on. And then because of that, we start to have this altered neurobiological attention emotion networks that occur with early emotional behavior problems continue to escalate, right? Then you have kind of these coercive family processes that occur to get done what needs to be done, or to make things, people act in a certain way. And then we kind of have this behavior escalation or early psychopathology that starts to form in elementary school. ADHD could be one of those, or an example of those. And then we see kind of these psychophysiological adaptations that start to occur within the body and the system itself biologically, right? Maybe inflammation's occurring more because those systems have been interrupted. Then we kind of lead to this poor social skills, leadership's conflicts, which then feeds itself and leads to peer rejection, which then moves to internalization and externalization of psychopathology. And we do see that, right? That if I can't trust what I think and feel, I then look to my environment to tell me what to think and feel. That's kind of what we're talking about, this internalizing and externalizing psychopathology. And then you can kind of see this idea of difficulty with regulation, or being biologically, the emotional reward circuits start to not be as effective as they could be. And that's kind of where that intergenerational transmission starts to come into place. And then we have health risk factors go up. And that's what we're seeing in the ACEs studies, right? That's very true. And then we have kind of this deviant peer group affiliation to feel connected because I don't know where I fit in or connect. I was talking to a young man just the other day, highly suicidal. He's gotten on the app. He's taught me about this. I'm a little out of it. Have you heard of Discord before? Um, if you work with adolescents, you have. Allison nodded. She definitely has. So if you Discord is where you can get on, and adolescents just get on and talk to each other. Anyways, this young man will get on and talk about suicide ideation with all his friends, and they all talk about how they want to kill themselves. Life's really tough. It's been very difficult, and that's a part of that affiliation, right? If you want to fit in that group, guess what you talk about? Suicide. That's it. So you don't have to be highly socially skilled. You just talk about suicide and you at least have some connection, right? Which is building that process for him. And then you can see this poor school achievement starts to occur, unemployment. And then again, the inflammation in the metabolic system, the allostatic load, we'll talk about in just a second, but allostatic load gets overwhelmed and you have maybe a low load that occurs or a high load, right? And then a poor spouse or partner selection, then hostility and relationship or conflict, adult psychopathology, and decrease in early mortality is what we see. And then you can see how it kind of feeds itself generationally over and over. I know there was a question.
I'm answering in the chat.
Oh, perfect. Okay, great. So hopefully as you're going through, you get a sense of what we're talking about here, right? And this idea of here's one idea based on these processes or these mechanisms, how emotion dysregulation builds over time. And it really is a process. It's not just something that occurs, but it's a process that gets reinforced over time. One thing that was kind of neat about this young man I'm working with, um, we've started to do some intervention to work with him on just fitting in and connecting and what relationships look like. And he's got on some medication. And the other day he said to me, it's been about 2 years of just high suicide, high depression, getting on Discord, talking about suicide. He's like, you know what I wrote on Discord the other day? I said, what? He's like, Brad, for one of the first time in my life, I felt joy. And and he said, I told my friends on Discord, and I think I might have lost a few of them. And I thought that makes total sense, right? Because he said, here I was telling my friends I was feeling joy, and we didn't know how to connect after that. And he's starting to see this disconnection that's coming, but having this increase of joy and decrease in suicide. So as we talk about allostatic load, this concept's important to know. It's this idea that on the one hand, it's kind of our stress level, right? It's what we consider our stress level. So you may have a low stress level, and here's the thing: stress is not all bad. In fact, stress actually can help us be functional, effective, get things done. It actually can help us with our performance and deadlines kind of stresses me out sometimes, right? And the reality is they actually help me perform. The problem is when our stress level gets too high, when it's too low, right? We're underloaded and we have low morale. When there's kind of this optimal level of stress that we need, right? That we can hit. And then on the other side, when it's too high, you can see it kind of troughs, right? And then there's kind of this breakdown. We're overloaded. We go back to low morale, go back to low motivation. I'll show you the next slide. You can see it even more. This kind of shows you in terms of those environmental biological stressors I was telling you about or showing you. So this looks at what are the environmental stressors, what are the physiological stressors, and then trauma or major life events. All of these really contribute to what we know as your allostatic load, right? And then, of course, we have individual differences. I showed you a lifespan development model, right, that kind of talks about that and can share about that. And then you also have just your perceived stress and how you perceive it, your behavioral responses, whether they're adaptive or maladaptive. And then that leads to this physiological response that then occurs. That's where that fight, flight, freeze comes in, and your overall allostatic load that occurs, right? So um, you can see it's this cumulative physical and mental wear and tear due to chronic exposure to stressors that really we see. And so the impact of having this overload and this chronic stress that occurs, this is how we physiologically see it with hypertension, high blood pressure, immune dysfunction, metabolic dysregulation, psychologically, we see it with mood disorders, cognitive decline, substance use, and sleep disorders. And then emotionally, the way we see it is very similar to what we'd say psychological, but fear, worry, anxiety, emotional reactivity, decreased resilience, and lower ability to regulate emotion. So hopefully, as you kind of conceptually understand the lifespan development that we're looking at, and then understand allostatic load, how important it is that we're really starting to understand and look at ways that we intervene, right? Not only to help each of these areas, but how do we intervene in such a way that increases ability to emotion regulate, increases ability to increase your allostatic load or distress tolerance, and help in that regard. The research is actually showing us for those with suicide ideation, um, looking at and identifying and increasing distress tolerance and emotional regulation are critical pieces. So here's some things that we don't know, but we want to know. And I think this is important. These are some hypotheses we can make from the research, but aren't necessarily all proven true. And I think this is where the further research is needed. So as we look at all behavior ranges from typical to atypical, so this idea that you have maybe that first thought of death and then a preoccupation with death, or start to plan, right? Then passive suicidal ideation, then active suicidal ideation. This is an area we want to understand more because we're trying to understand in the research what really is leading. I mean, I think the question earlier is like, we have this self-injurious thoughts and behaviors, which then lead to the first thought of suicide without a plan or intent, is how we often talk about it, but there's probably a gap in there somewhere that we're not understanding. And that's really kind of this idea of what we don't know, but we may hypothesize occurs. And so hopefully we see more research, but also hopefully this helps you understand this could be part of what's getting us to that attempt that occurs. So that's kind of the first one. The second one is there's this kind of this change across development. And so changes in expression of self-injurious thoughts and behaviors. So it's this idea of we may move from wishing to not be here to wishing we were never born to active thoughts of killing oneself, right? And then the same thing, are we seeing these changes in risk factors? If you look at early childhood to preteen and adolescence, do we see the same thing occurring where you have exposure to family conflict, which then leads to bullying and isolation in preteen, and then in adolescence, we're really seeing kind of this victimization, strained parent-child relation, and all of these being risk factors associated. I think in adolescence, we have a lot of those. We're going to share some of those today. We know more in adolescence. Again, we know less in the preteen, early childhood risk factors because of the research. So and then principle 3 is kind of this movement of self-injurious thoughts and behaviors across development. Is this doesn't look so linear, does it? As you kind of look at your first incidence of non-suicidal self-injury can be parallel to suicide ideation, or what we did see is it might start even a little earlier for suicide ideation that then leads to non-suicide self-injury, and then suicide ideation leads to the suicide behavior. But you can see this is just hypothetically within one person, how we might progressively move, and what are the arrows show the established links we know, the others we just don't know. So we're getting there, but I think this is important to be aware of. So and how that really across development. And then, of course, there's kind of the early intervention and prevention efforts. I think the research and understanding more is critical so we know how to early intervene. I think we're getting better at our early intervention efforts, but I don't know that we fully know where or how always to intervene in that process. So being able to, it will help us further to identify what are potential intervention points that we can have, right? And when first emergence of suicide ideation occurs, if we can get in early and early prevent there, we hope that will decrease all the other factors that we're looking at. And there's a lot that are a lot of early interventions being done in school, right? There's social emotional learning. DBT in schools is happening as social emotional learning, which is fantastic. There's what's called the Hope Squad. That's something in the state of Utah and a few other states that are doing there's just things we know, and we just don't know a lot about those interventions yet and how preventative they truly are. But we're trying, right? So I think that's the other one to just kind of identify and look at. This was some great research with Sheila Crowell. And I think this was an important factor as we look at the biological and also the environmental factors related to what's leading to suicidal ideation and self-injurious thoughts and behaviors. This was really interesting research that was done. So what they did is they looked at mother-daughter behavioral and psychophysiological reactivity during a conflict discussion. So basically, they took a mother and daughter together. They had them engage in a conflict discussion, and then they measured them physiologically, what their responses were, and coded their behavior to see what they could see, right? And how did it impact, and what was the influence on each other? A lot of times I was meeting with a group the other day, and they're like, oh yeah, of course it's mom's fault, right? That's an assumption that occurs. Well, mom created and took this kid, made her feel bad, and that's why she wants to hurt herself or have suicide ideation or suicide attempts. The other question might be on the other side is we have a highly sensitive daughter, right? Due to epigenetics or child, son, right? Whatever it may be. In this case, it was daughter. And is her behavior really driven by mom's behavior or not? And what is the influence? And so really understanding that, I think, was important. And this was interesting to me, and I think might surprise some of you. But so basically, they looked at the behavioral responses, they looked at the physiological responses, and they just created classification of behaviors, right? And did it based off classification of behaviors. So these were the predictions, and I'll tell you the results. Mother's evocative behaviors. They looked at in these dyads, so in the mother-daughter dyad, with a self-injuring teen, right? Someone who's engaging in non-suicidal self-injury. Mother's behavior drove the teen's physiological and behavioral responses. So that's interesting, right? But that's, again, when the daughter had met criteria for self-injuring already, okay? So in the dyad with a depressed teen, no self-injury, but potentially thoughts of suicide, mother behavior drove teen behavioral responses, so meaning her behavior would come about, but not physiological responses. So there was no, mother did not drive the physiological response, which I think is interesting. And then when they looked at the dyads with a typical teen who wasn't depressed or didn't have any self-injuring behavior, mother behavior did not drive teen physiological or behavioral responses. I think it's fascinating, right? When you think about it, if anybody is surprised by that, and maybe based on assumptions that we make. And so I think that's something to think about. And then here's the other thing across all groups. So they then looked at, okay, does teen behavior drive mother behavior? And here's what they found. Across all groups, teen behavior did not have a driving effect on mother behavior or her physiology. And some of you might be saying, well, I see the opposite, right? When I work with teens. So think about that. It's interesting. It didn't drive her behavior or physiologically. So the findings do support sensitivity theories on the development of self-injurious behaviors, but also we could say finding support sensitivity theories that those with high non-suicidal self-injury, but also those potentially at risk for suicide attempts, because those lead to each other over time, is what we're seeing, might just be more sensitive. And so that's interesting to note. And daughter sensitivity doesn't necessarily drive mom's behavior. And so I think that's important to be aware of as you're kind of going through and having context as you think about those things. So
I'd be really curious to see a study where we're looking at highly emotionally sensitive teens and emotionally sensitive parents.
great point. Yes.
That transacts on a whole new level.
Yeah, I think Allison, that should be the next research study, because the reality is you have two high sensitive individuals. And I think that speaks to that lifespan development, right? Because if it's intergenerational and both are highly sensitive, what does that look like and how does that differ? And I think we see a lot of that, right? And you can speak to that too, as we've had.
Certainly so, yes. We see that a lot where parents have their own emotion regulation vulnerabilities that
Yes.
back with their child's vulnerabilities in really intense ways. And our job is to try to bring awareness of that and intervene. So as we speak further about this, we're going to talk about risk versus protective factors more specifically. So when we talk about risk factors here, we're talking about what makes someone more vulnerable to suicide ideation and behavior specifically. So they may also be risk factors for NSSI, or they may not. And reminder that having a risk factor does not definitively predict that someone will have suicide ideation or behavior. Though it could occur. It also may be true that the risk factors are cumulative or have a cumulative impact on the person that's experiencing them. So someone with one risk factor may have a different level of risk than someone with 5 or more, for example. When we're talking about protective factors, we're looking at what keeps or prevents someone from acting on their suicide urges. So having those thoughts, maybe even progressing to planning of suicide, but what prevents them from actually attempting? This can also be cumulative, right? Having more protective factors in place could enhance protection rather than having very few. When we're assessing overall comprehensive suicide risk assessment at admission at Evolve, we're looking at, what tips the scales here? Are there a lot of risk factors and very few protective factors? That may be a very concerning situation for the child in terms of our ability to intervene and work on safety management with them. Whereas they have maybe mild to moderate risk factors, but a lot of protective factors, that gives us a lot more to work with. And protective factors are important to remember because they're key information to highlight during crisis intervention when someone is acutely and actively suicidal. We'll talk more about that in a few. So if we're looking at general risk factors, and this is like in particular as what is listed according to the CDC, here are some general risk factors for suicide for people generally. And a lot of these apply more specifically to adults who are experiencing a mental health crisis. So we know that on an individual level, having prior attempts does make someone at higher risk for future attempts. We also want to look at the potential lethality of all of those attempts in their past to understand and attempt to predict what their next attempt could look like. So, and of course, we can never truly predict with absolute certainty what someone's going to do in their next attempt. And if we see that they have multiple attempts of low lethality overdose on medication, there's a higher likelihood that that would be their next attempt method too. And that would be something to explore in therapy is you keep using this same method of attempting. What's driving you to do that when this hasn't been successful? this may reveal other functions of the behavior aside from wanting to die. So that's an important clinical point to highlight. We know that mental health diagnoses in general are risk factors, and there are several diagnoses that can really acutely increase risk of suicide, especially someone who's in an active, like major depressive episode or manic episode, for example. We know that current substance use is a big risk factor, as people who are using, especially certain substances, are more likely to either intentionally or passively overdose with substances, particularly if they're doing IV drugs. We know people with serious illness are at higher risk. The level of hopelessness they might feel or isolation from society due to a severe disability can really play a role, as well as recent losses. So these are things that can certainly affect a teen, but may weigh differently on an adult who's lost their job, who's lost their home, they can't afford their mortgage, they have no income, etc. Impulsivity plays a big role. We do know that many people will meticulously plan suicide attempts, but a lot of the time this is a highly impulsive act. And being able to lengthen the amount of time between thought and urge and action is really key in helping to prevent successful suicide attempts. And of course, hopelessness is an understandable risk factor. Not believing there's any hope for your future or any hope to feel better is a huge risk. Relationally, we're looking at people who are isolated. Do they live alone, have very few friends or social connections, estranged from family members? We're looking at recent relational losses, like a divorce or having someone close to them die. Or this could even look like someone close to them recently moved away and they don't get to see them regularly anymore. If a loved one has died of suicide, that is a huge risk factor, as well as being in current relationships that are high conflict. Societally, there are a lot of factors that can contribute. For many people across our country, they may live in so-called treatment deserts where they don't have access to mental health care, particularly higher levels of mental health or substance use care that may be really needed in times of crisis. Being aware of suicides in your community is a big risk factor. We know that for adults and teens, what we call a contagion effect is really relevant here, where exposure to suicide can drive increase in suicides in the community. Access to lethal means is a huge component. Ready access to firearms is a huge risk for people, as we know this is a highly lethal form of suicide attempts. Stigma around mental illness, feeling like you're alone and you can't reach out to people for support, for fear that you'll be shunned or criticized or judged, and community violence. So for neighborhoods and areas in our country where there's a lot of gang violence or there's violence in the home, these can also contribute as risk factors. Thinking about some teen-specific risk factors, and these are things that we see a lot evolve. We're looking at recent loss of privileges. As adults, this may seem minuscule, but for a teen, if they don't have their smartphone, it feels like death, right? To not have ready access to their Discord accounts or their friends on social media, to text people, to listen to music, to watch TikTok videos. This can feel really miserable. Sometimes it's necessary to keep them safe, and we need to know this is a risk factor in terms of feeling hopeless or desperate.
I feel that way when I lose my phone too, Allison. So
yeah, I mean, the reality is we might all feel pretty hopeless and upset if we don't have our smartphones.
Right.
Yeah, fair enough. Recent academic challenges or failures. Did they just get kicked out of school for fighting or smoking weed in the bathroom? Did they just find out that they're failing all their classes and might have to repeat the 8th grade? These are devastating things for an adolescent and are true risk factors. Relationally, we have being bullied. This is a significant concern both in schools and on the internet. Having a recent breakup, especially for a teen who is a big and intense feeler, going through their first breakup, you feel like the world is ending. This can be a time where teens need a lot of support. Alongside the piece of being bullied, we see being rejected from a societal group is really devastating for a teen. It can be a risk factor. Like, my friends just all told me they are not going to hang out with me and they're not going to invite me to parties. Or if you have a teen who is newly sober and is trying to burn bridges with friends that use for their own good, that could still be a risk factor in terms of their societal support and social connections. And that definitely needs to be taken into account. Rumors and gossip at school and school isolation. So I know that throughout the pandemic, for some kids, being separated from school was a helpful thing in terms of their mental health, right? We know that some data has shown that rates of suicide or risk of suicide actually increased when kids left lockdown and went back to their school situation. Which, the assumption is that being at home and alone may have driven that. And that's not necessarily true, though it can be for some kids when they don't have a consistent schedule, they're not around their friends, they're not behaviorally active. For some, that can really contribute to increased depression, which can lead to increased risk of suicide for some. And societally, for teens, there's a lot to do with contagion. So discussion of suicide on social media, reports of celebrity suicides, like when they hear that their favorite rapper just died of an overdose, or so-and-so is in the hospital because they attempted suicide. This can all be risky for our teen clients to hear.
Allison, one question Sarah had was relating to academic challenges. Is perfectionism a risk factor?
I'd certainly say so, yes, because for some of our clients who are more emotionally over-controlled, who are more on the rigid or obsessive and perfectionistic side of things, having a perceived or real academic failure can be devastating. So absolutely. Or college acceptance letters or lack thereof, that can be devastating.
Yeah. Yeah, I think it also relates to kind of the emotional dysregulation we were talking about and the environmental factors related to that, because you have an invalidating environment. So the way I try to prove that I'm enough, right, or deal with that is by measuring myself to be perfect. So it's that we talk about out of control behavior so often, but the over control behavior is almost just as difficult and still has similar outcomes, right? So
Yeah, and the problem with the over-controlled kids is that everyone around them usually thinks they're fine
yeah.
because they won't tell anyone how miserable they are. They want to put on an appearance that they've got this. And then family members are shocked when they realize they've been cutting or
Yeah.
that they've just attempted suicide. It can be
Yeah, and
very
in treatment centers, those are the kids who are like, man, we should put them on the payroll because they're just doing so
Yep,
well, right? Yeah.
yep.
And so we unknowingly reinforce the function of that behavior, right?
A lot of apparent competency.
Yeah, yeah.
So switching over to protective factors, I mean, a lot of these are pretty intuitive, right? They make sense pretty intuitively to most people, that having the ability to experience hope is a huge protective factor. Obviously, this is like significantly impacted by the presence of major depression, for example, or persistent depression, where an aspect of that disorder is hopelessness. You might not have this if you are in a major depressive episode. And being able to find moments of hope and be able to think in a future oriented way is a big source of protection for kids. Having supportive relationships is key. Having a best friend, having a community, and hopefully that community is not reinforcing or glamorizing suicidal behavior or self-injury. but having parents they can talk to, having a therapist that they can trust and reach out to when in crisis. A big thing that we see a lot with our teen clients is, I don't want to do this because I know it would devastate my little brother, or I wouldn't do this to my girlfriend, she would be devastated, or I don't want to leave my dog. My dog, it means the world to me, and my dog would be so sad if I didn't come home one day. These are big things for our teen clients. Having life goals. So in DBT, we call them life worth living goals because so many of our clients in DBT are experiencing a lot of despair and misery and are having a hard time figuring out what would make their life experienced as worth living. So being able to help them envision this and define what that would look like and how they can actively work towards a life experienced as worth living is a really key process. Fear of death and is a big protective factor. I would often coach our clinicians at Evolve to clearly ask our suicidal clients, what do you think happens to you when you die? And their answer to that can really inform our therapeutic approach. If they say, you know, they may have, as the last bullet point suggests, they may have religious beliefs that condemn this or cultural beliefs that condemn this. They may believe that they will go to hell or that they'll never see their family again. If they have those fears or belief systems, this is something that we can highlight when they're in crisis as a protective factor. I think some people are also like, I don't know what's going to happen. And that scares me too. Or they might feel like, what if I fail at this and then I'm disabled the rest of my life, or I'm in deep pain and misery physically from what I've done. Those are, valid fears if you're going to attempt suicide, and things that we can also highlight as protective. So when we're working with clients who have suicide behavior history, we really want to make sure we understand the thorough history of that ideation, behavior, and lethality. So using a tool like the Columbia Suicide Severity Rating Scale is really important and useful because it helps us to understand recent and lifetime occurrences of all these things. So how does ideation progress over time in intensity, frequency, duration? How does behavior, meaning like actual attempts or self-interrupted attempts or times others interrupted you, and how potentially lethal all of those things were. This gives us a good overall picture of the level of risk we're working with when a client isn't actively suicidal in front of us. There's other options too, like something called the P4 screener, which helps us to screen past attempts, suicide plan, probability of completing suicide, and other preventive factors. And then there's some other tools to help assess and manage risk in the moment. And so one that we use frequently in DBT is the Linehan Risk Assessment and Management Protocol, or LRAMP. So I'm going to go into a bit of the core components of that in terms of discussing intervention tactics. So the LRAMP overall, created by Marshall Linehan, has 7 sections. So we're identifying why we're completing the assessment, meaning have they just told us their thoughts of suicide are really intense? Did they threaten to kill themselves? Did they recently attempt, for example? We want to really behaviorally describe what occurred. We want to do a suicide risk assessment. So here's where we might bring in something like the Columbia to understand the big picture of risk. We want to look at acute suicide risk factors that are present. So things from a few slides back, like they just had a really chaotic breakup. They found out they're failing all their classes, et cetera, et cetera. And any protective factors present, like trusted relationships, hope for the future, goals. And then we're going to focus on how to manage that risk in the moment. And then there's a final disposition where you kind of wrap up what next steps are with your client. So we're going to focus specifically on the risk management piece. So this is what we would do when we have a teen client in front of us who's saying, I want to die. I'm thinking about a plan of how to do it. And I think I might actually do this. So this is when we're, we may have plan, we may have means, may have intent. And it's our job to kind of talk them through this crisis and hopefully be able to coach them towards commitment to safety. In DBT, we focus a lot on avoidance of hospitalization unless absolutely necessary, because we know that that intervention does not necessarily improve treatment outcomes. In fact, sometimes it can be actively treatment interfering in a lot of different ways. Of course, it should be used if there's risk we can't manage and we believe this person's life is imminently at risk. And our job first is to always try to coach them down. So our first step is to always provide emotional support. Tell me what's going on. What led you to feeling this way today? So let me describe to us their scenario where, I just, my boyfriend just broke up with me and now all of his friends are going on Instagram and telling me I should kill myself and I'm awful and all my friends aren't speaking to me. I just feel like this isn't worth it anymore. Our first step before we do anything else is to really connect with what they're experiencing and let them know that this sounds really painful. Makes complete sense that you would not want to feel this misery anymore. This sounds awfully miserable. To have this breakup occur, to have his friends attack you, that sounds really terrible. Okay, so a lot of authentic validation. Okay. Validation is key because your teen client is not going to want to listen to you or work with you if they feel like you don't get it. It's also very regulating. It can help regulate intense emotions to feel heard. And we're going to identify prompting events. So it sounds like we're already exploring that, right? Like what sent you down the path to thinking about dying today? Okay. This is important because there may be a problem that we can help them solve in this moment. And if they solve that problem, they may not want to die anymore. It also gives us insight into what's causing their distress, how we can effectively validate. So identifying what sent you down the path towards this is really key. So then once we have an idea of what's going on and how and why they're feeling this way, we want to give a little summary. This also is a way of validating, reflecting back what their experience is so that they feel heard and to make sure you have it right. Because you really want to clearly know what's going on for this kid if you're going to be able to help them. So that could sound something like, sounds like the fight with your boyfriend left you feeling really rejected and deeply sad. These feelings have been so intense, you started to think about ways to end the pain, which led to thoughts of suicide. You then started playing how to get into your parents' gun safe. Does that sound right? Okay. And a side tangent on gun safes. We've had clients tell us that they set up hidden cameras in front of their parents' gun safes so that they can record parents putting in the code so that they know how to get into it. Which is a frightening thing to hear. My recommendation is always to just not have them in your home at all if you want to be sure that your child is not going to have access.
Allison, there's a question here that's really good that kind of does with validation. It just said from Christina, are there studies that look at decreases in physiological arousal when validation occurs? I can't think of any off the top of my head. You may have some, so.
I can't either, but I wouldn't be surprised if there are. I think that I'd have to look into it, but I wouldn't be surprised if there is studies that involve the DERS, for example, which tracks emotion regulation ability over time. I would be curious to see if there are studies specifically tracking changes on the DERS with validation.
Yeah, it's interesting because we'd really be looking at almost a similar study to the one I was sharing about the mother-daughter dyad. That was one of the first real-time ones. So that maybe we need to talk to Sheila and have her have her do one where she checks the physiological arousal during validation. But I like the thought. So
Yeah, absolutely. So assuming we understand the client's scenario accurately, next step is any option for problem solving. So can the situation that's causing their distress be changed? Sometimes that's not possible, but it might be. So that could look something like, I hear that you're feeling very lonely and that this is contributing to thoughts of suicide. Is there someone you can call or text to keep you company? This may be a quick way to solve that problem. Or can the prompting event be removed or avoided altogether? So I'm noticing that you tend to feel this way after spending time with certain friends. Is it possible to take a break from these friends? Or is it possible to log off Instagram for the night since you're being flooded with these cruel messages? Okay, so being able to block the prompting event that's fueling these emotions and thoughts of suicide, if that's possible, let's do it. Okay. Also, looking at changing maladaptive thoughts around this. For obviously, this is long-term work, and in the moment, we need to challenge unhelpful thoughts around how to solve this problem. So we always let them know, wanting to escape emotional pain makes sense. Of course, I wouldn't want to feel this way either. And suicide's not an effective way to solve that problem. It's a permanent solution to a temporary problem. Your mind is telling you right now that I'm going to feel this way forever. I'm never going to have friends again. No one's going to love me. All these really scary thoughts. And that's what our mind tells us when we're depressed, we're in crisis, when we're emotion minded. And I'm here to remind you, these thoughts are not necessarily accurate, right? This problem is intense right now, and it may not be as intense tomorrow, and it very likely will not be as intense next week. So let's not do anything permanent at this time. Sometimes people have discomfort around validating the desire to escape the emotional pain because they fear that that will encourage them to attempt suicide. What's key is that you pair this with, and this is not the way to solve that problem. There are other methods of dealing with emotional pain other than something that's permanent. Next, we're going to coach them to use some safe coping skills. So we may be able to functionally help them solve a problem. We may be able to challenge thoughts around this. We may be able to help them regulate via validation. And chances are, like, we're going to need to walk them through some distress tolerance or emotion regulation skills, because typically in these crises, emotions are at the wheel, and intense ones at that. And so connection with values is not paid attention to, connection with reason is not paid attention to, and we can't access any of those abilities until the level of distress is lowered. So this means doing something to regulate your nervous system. Like in DBT, we often ask our clients to do ice dives. Put your face in a bowl of ice water and then notice how your body feels different and more regulated after you've done so. It's a very quick and effective way to lower distress and really create more clarity in the body and the mind to be able to make more wise decisions. We may want to have them engage in some motion regulation skills, whether that's checking the facts on what's causing their emotions or trying to act opposite of it. But I'd say in most cases, distress tolerance is what's most helpful here. And because we know that emotions, even intense ones, come in waves, they don't go up and stay going up and up and up to infinity. That just doesn't happen, no matter what our emotion mind wants to tell us. We know that they're going to crest and fall at some point, as well as the urge to die is going to crest and fall at some point. So if we can distract them with an activity that's safe, if we can have them do some paced breathing or do some intense exercise or something else that will help regulate their nervous system and and give space between them in a prompting event, that's how we get them to ride that wave of emotion safely without needing to act on their urge for suicide. We usually find with a lot of our clients that this is maybe, and it's different for different kids, but this is a several-hour period where they're in acute crisis. And if we help be the calm ship in the storm as they sail those rocky seas, then we can get them to the other side safely. We also really want to reinforce safe and effective behavior. So we can highlight, so first of all, I appreciate you came to me and told me that you're feeling this way. I love that because now I have the chance to help you, right? And that's the first step, is letting someone know how you feel. I also noticed that maybe you've been feeling this way for a couple hours and you have not tried to hurt yourself. I mean, that's amazing. I also love that. And how were you able to do it? Chances are they were probably doing something skillful in that time to try to get through that moment. And we want to highlight and praise that, really reinforce that, so they can also know that there's a skillful self in them that we need to highlight and strengthen. Because a lot of times our kids feel like nothing works, nothing helps me, skills don't work, no therapy works, I'm just doomed to this. And usually the reality is that they are being skillful in ways that they're not noticing, and we can highlight and build on that. And importantly, we want to generate hope. So remember how important your dog is to you. How you told me when we first met that your brother is so important to you and that leaving him behind would devastate him. Think about that when we make our choices. And we also want to highlight the ability to recover from past crises. So with our clients in residential, often we're seeing them through these crises, sometimes multiple times a week. And I'd be like, I know it's been a really rocky ride for you this week. And I want to remind you, last Tuesday, you were in this exact same spot. We talked it through and you did some excellent skills work. And you came out on the other side, willing to work with us to stay safe, recommitting to your safety plan, and really realizing, wow, that I was in total emotion mind. And now I'm looking at that now and realizing I don't want to be permanently dead, because that's what we're talking about too. We're talking about being permanently dead, right? And you're highlighting their ability to recover. You've recovered then, we can do it now, let me help you. Okay. So again, this is what we're doing a lot with high acuity adolescents. In residential care and in like lower levels of care too, or even with clients that are working on an outpatient basis. This is something that DBT clinicians are doing on an outpatient basis all the time, sometimes over the phone at 10 o'clock at night in phone coaching. So we're going to always follow up with a crisis plan. So we've gotten them to commit to safety, hopefully. And that means that we need to figure out what they're going to do to maintain that. So what safe and effective coping skills are you going to use? Who are you going to call, or who are you going to seek support from if you feel like you can't use that plan anymore, or you just can't do this? Is there a crisis line we can link you with? We want to get commitment from them to follow this plan, and then a follow-up time to check in. Say, okay, so you're committing to doing X, Y, and Z. We're clearly laying out all the action plans, and I'm probably going to make sure the client has this in writing to look at. Let's follow up in 3 hours or tomorrow morning or whatever that might be. So there's accountability. Like I'm gonna call you, or I'm gonna see you tomorrow in session. I want to hear about what you did. And identifying potential barriers. So suppose you do your ice dive and that doesn't help you feel less distressed. You're still feeling like it's difficult to not act on suicide urges. What can you do as your plan B? What do you do if your skills aren't helping? What if the prompting event recurs? What can you do to problem solve? And can you create a backup plan for all those things? Other skills to use, other problem solving. All of this is key. Of course, your client, we have to have a reasonable ability to believe the client is capable and committed to do these things. right? Or it might be a different level of risk and a need for higher intervention on an outpatient level. And the goal is oftentimes to be able to help get them through these crises safely, and hopefully reduce how often these crises occur over time. Okay.
We've got a few questions, Allison. One one thank you to Trisha for sharing. She did find a study by Frizzetti and Schenk that 2011 that did talk about validation. So that's awesome. I appreciate her sharing
That's
that.
not surprising
Yeah.
from Rossetti. That's great to
Yeah.
hear.
I'm just glad she knew the reference. That's awesome.
Yes.
But this was one question. What are the most vulnerable populations of teens? Is it the LGBT community or certain ethnic group? And I'll answer a little bit, and then maybe you could answer some, Allison, on this. But we do know ethnicity is a factor, and especially among our LGBTQ community, we do see higher rates of suicide risk and suicide as well occurring. So, anything you want to add to that?
Yeah, I think that I agree with LGBTQ community being particularly vulnerable due to society's response to their existence primarily, right? Or lack of affirmation or acceptance. And I think, I'm guessing, but would have to consult the literature. My guess is that similar risk factors that apply to adults probably also apply to teens in terms of ethnicity. So looking at indigenous populations being particularly vulnerable. And beyond that, of course, like even multiple risk factors such as like indigenous people who also have substance use disorders, or imagining even our LGBTQ indigenous teens and folks could be at risk similarly. Is there anything to add to that?
No, I think that's perfect in terms of those are what we were seeing as far as those groups and the reality is I think when you think of any marginalized group, we know that's one of the risk factors in and of itself, right? So,
Yeah.
yeah, we're happy to answer other questions that you have. If you've got them, please put them in the question and answer, and we'll be sure to attend to those. So, it's awesome to be with everybody.
Mhm. I see someone, oh yeah, studies measuring the physician's empathy with the patient has a positive impact on physical and emotional coping.
Yeah,
Absolutely.
which makes sense. It's interesting and I think as we look at soft skills, right, for providers
Mhm.
and how important that is across the board for therapists especially, but as we look at providers, medical providers, mental health providers, that's a really critical thing. One thing that we're doing in our program in social work that's happening is the use of VR or virtual reality. If you haven't seen it, there's the Vision Pro that came out with Apple, MetaQuest with the other one, but they're actually using VR for physicians and in mental health sectors and training to teach empathy skills and do it in a really concrete way to really teach these bedside manners because they're that critical and important. So interesting.
Mm, that's a great point, Tracy, saying that lonely adolescents are losing out on brain development
Mm.
experience.
Yeah, when you look at kind of that lifespan developmental model, right, of they're fitting in some of those environmental factors and behavioral factors that are really contributing and occurring. That's a great point. Yeah. Excellent thought, Tracy.
Right. Any other questions for us? Thoughts or takeaways?
Oh, Sarah, I didn't know this. I'm gonna have to check this out. Sarah was just saying Meta just released their exposure therapy VR app today.
Oh,
It really, if you if you have not seen VR recently. It's fascinating what we can really do. And I think we're only going to see it more in our training, in our schools in related to getting people up to speed in the healthcare industry and human services to be able to really attain those soft skills. And I do agree. I think we're going to see it more used in therapy as well, especially exposure makes a lot of sense. I think we're going to start to see it in a lot of other areas as we grow that evidence base. So thank you for sharing that.
In the Q&A, we have a question about previous attempts, and you said that, asking why they choose that method when it's not effective before. Oh yeah, certainly. So this is a question I like to ask in DBT because it helps me understand the function of the behavior. A lot of our teen clients will engage in suicide behavior without the full desire to be permanently dead. And so I also asked them that question. When you did this, did you want to be permanently dead? Meaning that you would no longer be here ever again. This is done. And a lot of times they say no, that maybe if that did happen, I would guess I would be okay with it. But I really want to break from the pain, a break from my situation. I want to be away from here and in the hospital, or I really want to communicate how intense my pain is to all the adults in my life. And so I think that when I ask, last time you took two handfuls of Advil and it did not result in your death. You've done this again. Tell me more about that. Like, what was the purpose of doing that exact same thing again? And what stopped you from doing something different that you felt would be more lethal? I think their responses to that are very really revealing.
Yeah, great point.
Um,
Yeah, I'll read this one, Allison. Any thoughts on how to include teens' parents in prevention as you're kind of talking about that?
Yeah, I mean, I think I really recommend having parents be involved in the safety planning process. And of course, like balancing client confidentiality with the need to involve parents as like typically primary modes of support in the home environment, that if there's a safety plan that the client's committing to, parents need to know about that and be able to participate in it and reinforce its use. Obviously, if there's a reason why that would be safe for the client, that's a different consideration. But most of the time, I think their active involvement in that is really, really key.
Yeah, great example. This was another question. Well, there's kind of two that came in. Are there any known counterintuitive symptoms that could indicate high risk for acting out suicidal thoughts? Any thought on that?
The first thing that comes to mind is someone that's been deeply depressed that's suddenly in a fantastic mood.
Yeah.
They're suddenly very goal oriented. They may, sometimes the reality is that someone may be too deeply depressed and almost vegetative from severe depression to be able to execute an attempt. And
Yeah.
if you're seeing some emergence from that, they may be at more risk than when they were the lowest of the low.
Yeah, it's interesting. I just had this conversation with a mom yesterday or 2 days ago. We had had this young man on some medication, and he was starting to feel some improvement with a little bit of decrease in suicide ideation. And she said, I think we're going to start to pull back and give him more freedom. I said, actually, now's not the time to do that, because the research shows us as they start to feel improvement, now they've got energy to act on the things that we're talking about. And we may want to just wait and continue what we're doing and see how he progresses. And so, yeah, very counterintuitive, right? Just in our natural response of, we think, oh, good, we're going to pull back and not watch as close. So that's a great point.
Yep.
This was the last one. Aside from all of our own takeaways from what was shared, what are some things that you all would hope that we take away from this?
Okay. I think the to be fearless in your ability to have these really difficult conversations is such an important part about helping suicidal youth, is to have these hard conversations and to name it directly, and to really truly and authentically empathize and validate with their experience. I think is
I
are
love that.
the biggest things.
Yeah, and I would just add, keep on the research, keep watching what we know and what we don't know, and acting accordingly, right? There's a lot that we do know, and I think keep understanding that developmentally, there's a lot we can do in terms of intervention to help our teens. We're not helpless in this, even though we may not know all the answers right in the process yet. So
All right. Well, thank you so much, everyone.
yes, thank you, everybody.
Take care, and I hope you all do great work.
All right. Thanks for spending the last 90 minutes with us, and please join me in sharing our appreciation for Allison and Brad. So thanks to both of you for a very informative and educational presentation. Thank you so much.
Thanks
And then
all.
Thank you. Great to be
watch,
with everyone.
yeah, watch your inboxes for how to get your credits, and then the materials will be available as soon as they are available. So thank you so much.
Thank you all.